Namaste students, Khusro with you. I JV'n Dr. Singh, SHEKHAWAT, Assistant Professor, Department of SHALYA, Faculty of Ayurvedic Science, Jayoti Vidyapeeth, One Sri Jaipur. In previous class, we discussed about ascites. Now, in today's class, we will discuss about appendix. Contents of appendix, definition, then pathophysiology, clinical features, diagnosis, difference, diagnosis, and treatment. Incident, as you can see, what is the incidence? Surgical anatomy. It is located It is located at the terminal end of the cecum where 3 T join about 2 cm below the ileocecal orifice, usually around 5 to 10 cm in size. Variable size of lumen. Mesoappendix is an extension of the mesentery, contains appendicular artery, a branch of which ileocolic artery. Often in accessory appendicular artery may be present. Thrombosis of 3 vessels leads to gangrenous appendicitis. For table demonstration, the mesoappendix with appendicular artery, note the appendix. Note the appendix: A. Mesoappendix, B. Cecum, C. Ileum, D. Ileum, C. Cecum. Note A. Appendix, B. Mesoappendix, C. Cecum, D. Ileum, and E. Sine coli. Okay, students. Different anatomical position of the appendix: A. Retrocecal, most common, pre-ileal; B. C. post-ileal; D. pelvic; E. subcecal; F. paracecal. Appendix. What is mean by appendix? Inflammation of appendix. Appendix is called appendicitis. It's really caused by an obstruction, lymphoid obstruction and infection. Predisposing factor for appendicitis: first, obstructive agents, and second, infective agents. Obstructive agent means foreign bodies, animal, vegetables, minerals, subcommunal lymphoids. Infective agent: primary infection leading to lymphoid hyperplasia. Second infection, both aerobic and anaerobic is also. Type of appendicitis is acute appendicitis, acute appendicitis with mass, acute appendicitis with peritonitis. Pathophysiology: acute inflammation of mucous membrane with second infection without obstruction cause acute non-obstructive appendicitis. It may lead into resolution, fibrosis, recurrent appendicitis, or eventually obstructive appendicitis. This one also another pathophysiology. Acute appendicitis thought to begin with acute appendicitis throat to begin with the obstruction of the ileum. Obstruction can result from food matter adhesions or lymphoid hyperplasia. Mucous secretion continues to increase in term luminal pressure. Eventually, the pressure exceeds capillary perfusion pressure and venous and lymphatic drainage are obstructed. With vascular compromise, epithelial mucosa breaks down and bacterial invasion by bowel flora occurs. Increased pressure also leads to arterial and tissue infarction, and result is perforation and spillage of infected appendiceal content into the peritoneum. As inflammation continues, Serosa and adjacent structure become inflamed. This triggers somatic pain fibers innervating the peritoneal structures, causing pain in the RLQ. Right lower quadrant. The change in the stimulation from visceral to somatic pain fibers explain the classic migraines of the pain in the periumbilical area to the right lower quadrant seen with acute appendicitis. Exception exists in the classic presented due to anatomic variability of the appendix. Appendix can be retrocecal, causing the pain to localize to the right flank. This is all about part first of appendicitis, include definitions, causes, and pathophysiology of appendicitis. This session is powered by Digital Session 2.0 Jyoti Vidyapeeth Women's University, Jaipur. I hope you are satisfied with this discussion. If you have any doubts and queries, please mention in comment box. I will resolve it soon. Thank you.